To be in medicine, you have to understand that it is a very long game. We will see less young physicians going to those places to train and to work. My goal with policy advocacy is to...
Hi everyone, my name is Irene, Chief of Staff at Oceanside Perspective. Welcome to OP's new series, Finding Purpose, where I speak to professionals who have found their passion and want to share their unique journey, experiences, and learnings with our audience. I'm here today with Dr. Alexandra Johns, PGY7 surgical resident at UC Davis. Dr. Johns, thank you for taking the time to have this conversation with me today.
Of course, happy to be here.
Let's start by talking about your personal journey to medicine. Could you briefly introduce your background and how you got to where you are today?
Yeah, my journey is maybe not super traditional in the sense that I'm the first and only person to graduate from college in my family. I come from a very blue-collar family from Ohio. Almost everybody in my family works for Ford Motor Company. Very proud UAW family. And I decided that I wanted to go to college at an early age, and I was really passionate about science. I went to a kind of local state college that offered me a scholarship because we didn't have very much money, and studied biology. Early on, I decided I wanted to do something impactful, meaningful, and I think that is an easy jump to medicine when you're looking for that kind of career. So I joined a pre-medical fraternity, did a lot of volunteering and research, and applied for medical school right away and was lucky to get in at Ohio State, which is the state college, one of the biggest medical schools in our state. Went straight into medical school and then chose surgery also pretty early on, worked through my 4 years to match into general surgery. Was lucky enough to come to California. I was very excited about that. And then through my journey in general surgery residency is where I've kind of taken the time to explore. I think going straight through from college to medical school, it didn't give me a lot of time to explore other careers and other passions. And I took 2 years off during residency to get a master's in public health, work for the Department of Public Health, do a lot of policy work with other surgeons, do a lot of clinical research. So that has allowed me to see other passions outside of just the clinical surgery part. And then now I'm going to be doing a fellowship in minimally invasive surgery and hopefully a job in academic surgery where I'm continuing my research and policy work.
Yeah, very cool journey. Thank you. So you spent most of your life in Ohio. How do you like California so far?
It's been great. My husband and I, we just got married right at the end of medical school, and we knew after we got married we wanted to go somewhere else. We didn't know where. I interviewed broadly, but we agreed that California would be our top choice, and we were very lucky to match here. The match is a difficult process, and not everyone gets their first choice. And so I did feel very fortunate to come to such a beautiful state. And Sacramento has been perfect. We started our family here. We bought our first house here. We have enjoyed the weather and traveling, and it has been the best place to be a surgery resident.
That's great to hear. Growing up, did you have a hero in your life that inspired you, and why?
I don't think I had a hero per se, and I do think that it's hard being the first generation college graduate because I didn't have a lot of people to talk about this journey. And I think talking with other people who are first generation college graduates, I think a lot of us didn't quite know what we were getting into. I don't know any doctors personally in my life until starting my medical school journey. And I wish I did. I think I would have known a little bit more and maybe made a more informed decision. So I don't know that I have like a hero that I looked up to, unfortunately.
Mm-hmm. Have you always wanted to be a doctor?
Mostly. My parents said as a little kid I described wanting to be a doctor, and my pediatrician used to tell me to not pursue that career. A lot of doctors actually throughout my journey told me not to, which is funny because now I sometimes say that to undergraduate students. And then in high school, I did a lot of biotech and interesting additional science courses that were offered through the community college and through my high school. And so I knew I liked science. I thought maybe I would go into chemistry or other fields in science, but then in college, the path to medicine it's pretty straightforward. And I think also for someone who didn't know what they were doing and didn't have people to guide them through college, like the pre-med medical school residency tract is laid out for you. And so it's easy to just fall into that rather than finding a career and a PhD or a research career or something that's a little amorphous. So yes and no.
Yeah. How did you first discover your passion for medicine? Was there a pivotal moment that convinced you to pursue this career?
Not really. I actually was the founder of the pre-medical fraternity chapter at our college, which helped connect me to other kids who wanted to be in medicine and then connect me to other like resources. But there wasn't anybody who really influenced me, and there was no moment where I was like, I'm gonna go to medical school. It just was this kind of like inevitability. And I really do think a lot of it played into this like safe choice of, if I got into medical school, there's a very high chance that you graduate. Most people, once they get in, graduate, and then most get a residency in their chosen specialty, and then once you graduate residency, you're almost guaranteed a job. So it was just this very like safe choice, which I did not like consciously know I was making that choice, but now looking back, I think that that's why I made a lot of those choices.
What drew you to general surgery, and why did you choose to specialize in it?
General surgery is the broadest of the surgeries. So I knew that I wanted to do something that would give me a breadth of knowledge. I didn't want to be so subspecialized, for example, like urology, where you're only working with one organ system and not understand all of medicine, not be able to answer the questions of my family members or my friends or my patients when it had to do with anything besides that organ system. And so when you want a wide breadth, you're kind of limited into internal medicine or general surgery. Surgery appealed to me because of the immediate results. I wanted a problem, a solution, and then results. I didn't enjoy treating chronic medical illnesses with medications that sometimes saw results in months or years or none at all. I didn't find that that was satisfying. I didn't like the long-term nature of those diseases and the illnesses that really debilitated patients. I liked surgical problems that were often fixable and patients returned to their normal life. Looking back now, I think general surgery is getting more and more subspecialized. So my training is very broad. My career will not be. If you want to be in big hospital centers, you will have to subspecialize. And I will probably end up doing more like foregut, bariatric, and hernia, and not be doing all the breadth of general surgery. But it was good training, and I get to, know almost every organ system, critical care, trauma, like the common things that affect the U.S. population. I get to know about.
So to give some advice for aspiring physicians, how does someone know that medicine is the right path for them?
I think that I was talking to Dr. Herr about this yesterday, that it's hard because asking me right now is like asking a woman who's mid-labor about having children. Like I'm not enjoying all the benefits of all the training. I'm still in the training. And so I think that being a surgical resident is a little bit of being a martyr. And I think that you have to be okay with that part. Being a surgeon, and some of the attendings that you talked to probably gave different answers because they're living a different life now. But the past decade of my life has been medical school and residency, and that has just been a grind. So you have to be okay with a 10-year grind. That was taking out massive amounts of debt for me. That was not making very much money as a resident. that was working very long hours, that was putting my fertility and my child and my husband through a lot, all in the end to get to this reward that I haven't gotten to yet. So I think to be in medicine, you have to understand that it is a very long game. In the end, so they tell me, it is worth it. And it is worth it in my day-to-day interactions of working with patients, of learning a new task, of, there's this constant promotion. So if you're somebody that wants to rise to the next level, if you're always looking to strive to rise to more, it's a great profession. My husband's a welder. He's been in the same job position for 10 years. That would be frustrating to me. I like the upward mobility. So there's always that. There's always a new task. There's always the new hurdle to jump through. So if you're willing to do that for 10 years, and then you want to work with people, you want to do things that matter to your community, I think medicine is right for you.
Yeah, in my conversation with Dr. Herr, he said it's a big investment, both financially and just the time that it takes for you to reach the light at the end of the tunnel.
Yes, not there yet. I see the light. I'm almost there. But it is a very different perspective, I'm sure, that he has on it looking back than I have on it right now.
Yeah, but talking to both Dr. Herr and Dr. Laundre, it seems like life is good at the end of all of it.
Yes, I also think that medicine has changed a lot in the 20 plus years that they have been practicing. Even I started residency before COVID. Even in the 7 years I've been in residency, things have changed. We spent a lot more time doing paperwork or computer work that I think our predecessors did. We spend a lot more time doing defensive medicine. We spend a lot of time with patients who may disagree because they Googled something and have opinions about their care. We spend a lot of time with frustrated patients who are mad about their insurance company or their primary care doctor or the wait in the ER that has nothing to do with my surgical care, but has everything to do with the system I work in that's very broken. Kaiser is a better system, but when we're at other hospitals, there are a lot of issues that we can't fix. And I think it's not that that wasn't present 20 plus years ago, but it's different now. Yeah. And I think it makes the job less rewarding, probably.
Yeah. What qualities or experiences do you think med schools are looking for in applicants today that might set them apart from others?
Medical school is really hard. There were a big group of us that applied, and I guess this was 10 years ago, and only a few got in. And it's not that those others weren't competitive, it's just that there's so many very competitive, very qualified people. My advice to students and also to residents seeking fellowship is to build a brand. When I sat in my interviews for fellowship, my brand was policy. I did research in education, I did things that didn't fit that brand, and I didn't talk about those. I talked about what fit my brand, because at the end of the day, the interviewer just interviewed 20 people, and they want to remember you for something. And so they will remember me as the policy girl. There are lots of brands. In general surgery, what I recommend to residents is, an education brand. You can be really passionate about surgical education. You can be really passionate about volunteerism or, pro bono care. You can be really passionate about global health. For undergrad students looking to get into medicine, it's the same thing. You can be really passionate about research. You can be really passionate about diabetes and work in clinics and do research on it or whatever, and you will be remembered as the diabetes girl. It doesn't matter what the brand is, but build that brand. It shows passion, it shows dedication and commitment. It gives you a depth of a topic rather than my resume going into medical school had a little research, had a little volunteerism, had a little this, and none of them really aligned. If they had all been in one brand, I could have really talked about policy or diabetes or education in depth, and it would have made me stand out. So it's hard to do that as an undergrad or as a person taking their gap years, but if you can really focus on something, dive deep, show commitment, you will stand out.
Yeah, that's really insightful, because I've been having conversations with various people along that process, like the healthcare pathway. And I'm hearing a lot of people who have basically everything under their belt, all the experiences, perfect MCAT and perfect GPA, things like that, but they don't get into med school. So I was just curious to know, like, what are med schools looking for? But I think your answer is really, really helpful.
I think you can do everything. And that was the advice I was given. You have to volunteer, you have to shadow, you have to do research, you have to have perfect grades, you have to tutor, you have to... So I tried to do all those things, but it didn't show a passion. It didn't show anything that I cared about. It just showed that I was checking the boxes. And sure, that's fine, and it looks great on a resume, but when you sit there in that interview and you're talking about something, you're just... It's surface level. Everything is surface level. But if you were really passionate about education and you got a minor in education and you tutored and you did research in surgical or medical education and all these things, you could then say, my career goals are to work in academic medicine. You just take it all the way to the end. In the end, if that's not what your passion is, that's fine. A lot of residents don't want to pigeonhole themselves, and I'm sure students as well. Like, I don't want to scream that I'm the education person. What if I don't like education in the end? But it doesn't matter. Build your brand, show your passion, and if in the end you change that brand, that's okay.
Yeah. What's one thing that you want people to know before choosing to specialize in general surgery?
If I could go back to myself 12 years ago, before applying to medical school, that person would have said that I was going to be Superwoman. I was going to have a baby, and I was going to work 1,000,000 hours, and I was going to do everything, and it was going to be so great, and that's what I really wanted. I had no idea how much having a family, growing up, having things outside of work would matter to me, because it didn't at that time. And I'm giving this advice knowing that 12 years ago I would have laughed at this advice. But anyway, it does matter. And finding a location of your medical school and your residency that is going to help you pursue whatever those goals are. If it's not having kids, maybe it's a lot of my friends that don't have kids that are surgeons are really passionate about going outdoors and skiing and hiking. You need to be in a place where you can do that. You cannot put the rest of your life on hold for medicine or surgery. And again, I would have laughed at that answer and said that, of course I can, but 10 years later, it's a long time to put your life on hold. And I didn't put my life on hold, but I made a lot of sacrifices along the way. We struggled with infertility, which is very common in medicine and female doctors, and especially female surgeons. Lots of studies have shown that. I struggle to raise a toddler and be a surgical resident. All of these things have been huge sacrifices that I thought I could just make without worry. And I wish I would have considered it a little bit more 12 years ago.
Yeah. So moving on to your working life as a surgical resident, what's your favorite or most satisfying part of your job?
There's kind of two areas that I can think of. There's one where when you really connect with a patient. As a resident, we're not the surgeon. We may not have seen them in clinic. We may not see them afterwards. And so sometimes there's this, we're just the assistant. And patients sometimes treat us that way, and we sometimes treat ourselves that way. We just show up for the case, we do the case, we move on. But there are some patients where you may see them first in the emergency room, do their surgery with the attending, follow them for their inpatient course, and you may be the only physician that they saw that day. And they know that, some of them. And they connect with you. And I have patients come back to clinic and say, Dr. Johns, thank you. Or patients hug me when they feel better after their surgery. That is the best feeling. And that's why I chose surgery. The other part is the connection with your colleagues and your attendings. I'll give you an example. Dr. Herr yesterday comes into the OR and we're prepping, and he puts on music, as we always do, and he puts on Taylor Swift. And I looked up and I kind of had a smile in my eye, through my mask, and he goes, "This is just for you because I knew that you would like it." And it was just so heartwarming that this person who's my parents' age cared enough to know the kind of music that I want, to know where I am in my journey of surgical training, to allow me to do the whole case, to really support me in my journey. Not every attending does that, but when you connect with a mentor who really guides you, who cares about you, it's like you have a team and you feel supported, and it's wonderful. So there's two aspects that really bring satisfaction.
Yeah, I've definitely felt the warmth and the beautiful environment that they've created here. So
yes, I will say it's not always like that.
Yeah.
Not every rotation that we have is like this, but you can feel when I come here and they say, "Lexi, you're here." They know, they know me. They are excited to work with me. They're excited to teach me something new. They don't want to just watch me operate. They want to teach me something, and I want to learn from them. And it's this exciting dynamic that I will lose after residency. So, pros and cons.
Hey, so a little break from our conversation. Oceanside Perspective is a 501c nonprofit dedicated to human skills education. So we would appreciate any support from you, whether it's liking this video, subscribing to this channel, or subscribing to our newsletter below in the description box. Thank you, and let's get back to our chat. Do you have a favorite procedure to perform? No?
It's just hard because as a resident, there are some procedures where I get to do start to finish, where the attending doesn't scrub it. So obviously those are my favorite, but those are not the procedures that I'm going to seek out more training so that I can do. I really love foregut stuff, hiatal hernias, anti-reflux procedures. Those are the things. I love the anatomy. I think it's a really beautiful dissection. They're challenging but rewarding, but I don't get to do that start to finish right now. I get to do a gallbladder, an appendectomy, a breast case start to finish, and so I get more excited about those cases at my current training level.
Yeah, that makes sense. So what's your working schedule like, and how do you maintain work-life balance?
Every rotation is different, which I think is one of the hardest things about residency, and one of the hardest things for my husband to deal with. This month, my schedule is I'm on call every 4th day. So I work 28 hours in a row, maybe 26 if I get out a little bit early. And during that time, I'm mostly at the hospital. If nothing is going on, maybe during the weekend, I can leave, but could be immediately called back. During that day, I'm rounding, I'm seeing consults, I'm operating, whatever comes in. The next day after you leave, you get the rest of the day off. And then the other days you're not on call, it's more like a 6:30 to 5 p.m. kind of schedule. On other rotations, there are some where we do weeks of night shifts. There are some where you do every 3rd day is call, and you're not allowed to leave the hospital. There are weeks where you work 6, 12 to 13-hour shifts, which adds up to just about 80 hours a week. That's the kind of service I'm going to next, where it's 6 12s. And that is almost more challenging to me than call, because I'm very, very tired at the end of every day. And at least with the post-call day, I get some time to take a nap and then go do things. But 6 12s, you don't get much time off.
Yeah.
So it's different. It's usually somewhere between 65 and 80 hours a week.
Wow. Yeah. I always wonder how you guys stay awake for so long.
I always tell people it's a skill like any other. You learn how to be tired. You learn how to tell when you're too tired, like when it's not safe to drive home. My parents are 3 hours ahead, which sometimes makes it hard, but it makes the perfect morning phone call because it's like lunchtime for them. And they know when I call, that they need to just keep me up on the phone till I get home. You learn how to kind of put that smile on your face and go see another patient at 4 o'clock in the morning. It's just a skill. It is something I recommend that med students do. I think med schools have gotten away from having students do 24-hour call, but I think the hard part about that is learn the skill early, not when you're responsible for patients. Just learn how to stay awake when you're a student and there are less responsibilities. It also makes you a better newborn mother because you can stay awake. The newborn phase was so much easier for me than it was for my husband because I had that skill.
I guess that's a perk.
Yeah.
So work-life balance includes balancing family as well as your well-being. We've had previous conversations about the additional risks that women physicians have to consider, especially if they plan on pursuing a surgical specialty. Why do you think there are increased risks of health issues such as infertility in women physicians? And what has been your experience so far as a mother and a surgical resident?
Yeah, so there was a recent study that just came out. It compared female surgical residents to male surgical residents' partners who were not residents. So they still had the male who was a surgical resident, but the woman was not actively doing residency. So it was a good control because it takes away salary. You know, they should ideally have about the same salary, all the other things. The female surgical residents had higher pregnancy complications, more preterm birth, postpartum depression was higher. This is all after you get pregnant. There are lots of studies, and I think a New York Times article a couple years ago about female physicians in general having higher rates of infertility and even higher in surgeons. They controlled it for age. A lot of people, especially in my family who are not physicians, will be like, oh, well, it's because doctors wait so long to have babies. No, even when you control for age of the mother, it's probably stress, it's probably sleep schedule, it's probably all the other things that come with our job, but no one knows. And me and my husband also struggled with infertility, and we never found a diagnosis. So it's not like we had some reason to explain. And we had to go through fertility treatments, which now UC Davis pays for, but at the time did not. It's expensive. It's time consuming. It's hard on a resident schedule to go through that. We have a couple other residents going through it right now. You have to have timed doctor's appointments, and it's tough. But then once you get pregnant, it's not like those issues go away for surgical residents. We are doing better. There are now rules in place where third trimester moms don't take 24-hour call. But you still only get 6 weeks off. They can extend it to 8 weeks postpartum. So you're putting your 8-week baby into a childcare facility or nanny if you can afford it, but most residents can't. And then, postpartum depression, very high because you're working 80 hours a week again. It's not like you have a graduated return back to work. You come back at 80 hours a week, 24-hour shifts with an 8-week-old. I will say toddler's not any easier. It's a whole new challenge. At least the baby is awake at sometimes during the night. My baby now sleeps through the night. So if I work 12 hours and she's awake 12 hours, I don't see her. If she asks where I am now, there's a whole different set of challenges. I will say a lot of people ask me if they should have kids during residency, and unfortunately for general surgery, that training period is so long, it's not really feasible for most people to wait. Even I, starting at the youngest you can start at for residency, am still going to be pushed, to have kids before training ends if I want to have more than one child. But a lot of my colleagues took some time off before medical school or before residency, and they're pushed even more. So you have to. And it can work. I had my baby during research year, which was better. I got to be home, working from home mostly for 8 months, which was great, but most of my colleagues get 8 weeks. And we figured out. You have to have a supportive partner or family, something to help. We are far from grandparents, so we don't have a village. We have me and my husband and our daycare. We make it work, but it's the best thing I've ever done. It is worth it. It is challenging, but it's challenging because you have so much good in your life between career and home, and who doesn't want extra good in their life, right?
Yeah, it's beautiful. How do you think the system can be improved for physicians and residents?
For pregnancy or for everything?
Yeah, for, I guess, like women's health and things like that, taking care of that aspect of well-being.
There are a lot of people working very hard on that. My residency program is unionized, which started in the time that I've been there. When I started, we did not have a union, and the union fights for salary increases, which has been very helpful. Since my daycare is about 20% of me and my husband's together take-home pay every month, 20%. Plus we have to pay for a mortgage and all these other things. So salary increases are very helpful. Working on things like protecting third trimester mothers, pumping. I mean, some of these are state and federal laws, but that unfortunately medical residencies have been lagging. There's a residency in New York where they are striking right now because they don't have health insurance, retirement, days, sick days off, adequate pay. So there are a lot of people fighting for these things. I think it's getting better. There's more and more studies coming out to prove, and physicians respond to the data, right? So the more we publish, the more we have fodder in our fight to fight against these things. But it's a slow process.
Yeah. So I'm curious about your fellowship after you complete residency. What will you be specializing in? Why did you make the decision to do additional training?
So I'm doing minimally invasive surgery, which is a newer specialty. It's about 25 years old. Prior to that, these procedures were done by general surgeons. And that's kind of how medical training in general is going, that there used to be these very broad specialties that a general surgeon or an internal medicine doc or something did all of them, and now they're siloed into subspecialties. So it's primarily the foregut, so esophagus, stomach, so things like hiatal hernias, reflux surgeries, and then it usually combines a component of bariatric surgery, although every program is different. My training will include bariatric surgery. And then there's some component of hernias, which again was typically done by general surgeons, but as it's getting more and more complex with robotic surgery, they're looking for people who have extra training in this. The reason I chose to do it is because I want to be in academics. I want to do research, I want to do policy work, and I want to work for an academic institution that supports that. And at this day and age, you can almost not get a job at an academic institution without fellowship training. To work in a more community hospital, you can be a general surgeon and just do your 5 years of training and get a job, but that is almost unheard of in these academic hospitals. I do really enjoy the foregut procedures. I think minimally invasive surgery also gives you better skills to be a better general surgeon, to use the robot more, to use laparoscopy more, instead of the old school open ways. So it will be helpful, but it is an extra year of my life. It is a move across country. It is, it's an investment for my family to get a job.
Do you think AI could eventually replace aspects of your job and change the way that you do patient care?
I get a lot of ads for AI note-taking with patients, which is interesting to me because of HIPAA rules. How does an AI stay HIPAA compliant? But I do think that the future is that a lot of my computer work will be done voice-activated AI type things. I think I'm probably training in the worst period of medicine, where we have all of this rapid uptake of electronic medical records and all of this computer stuff, but not the support systems to help physicians. So I think, my child's age doctors will probably have less computer work to do, which will be great. So yeah, I do think that. I don't think that there will be AI surgeons or like, truly robotic surgeons. There are some medical specialties that will replace, like radiologists, pathologists, maybe certain aspects of primary care or like urgent care. But I think surgeons are probably pretty safe from that. They are working on some remote surgery where the surgeon is in another city operating a robot that is operating. It's in an effort to help with like rural and underserved populations. Scary because that person is not there to immediately fix. You would have to have someone else there to fix any issues. Yeah. But there is a huge disparity in rural care, and I think we will use AI to try to, or some sort of, technology to help reduce some of those disparities, hopefully.
Yeah. Very interesting. So lastly, let's talk about the future of medicine. What's something that you wish medical education and training emphasized more?
Well, personally, I love policy, and I did not learn a lot about the current legislation, previous legislation, the state laws that surround the practice that you're going to work in. You are kind of taught all of this medicine, clinical medicine, and I get it. Med students have to learn so much more now than they did 50 years ago because we know so much more. But you're not taught about the system, and you're dropped in as an intern, and you have to work within Medicare, Medicaid, the state laws, the hospital laws, the federal laws, and you don't know them. So that's why I went back and got my MPH in health policy during my research years so I could learn about this. I then use that to advocate on my patient's behalf, on other physicians' behalf, primarily for surgeons, for state and federal legislation. And I think that there are not enough doctors who understand that process or understand the goals to even advocate for themselves or their patients. And it's a huge missed opportunity. And it results in a lot of burnout because doctors don't know how to navigate the system. They don't know how to change the system. And they're disappointed with their training and with this unfortunate burden that they're handed when they become an intern. So I hope we can start training people, even if it's just those who want the extra training, on health policy, on legislation, on how to get involved. It's something that I try to teach all of my co-residents. I've done talks, and I'll do a grand rounds presentation this year talking about it. But it shouldn't be on a single resident to teach the entire institution. We should have infrastructure to teach medical students and residents about this.
Yeah. In your opinion, what's the biggest healthcare challenge that modern people are facing, and what can people do to prevent it?
Oh, there's so many hot topics right now. Obviously, pregnancy care, maternal health is a challenge and tragedy. There were recent deaths in Georgia of women not getting adequate abortion care due to miscarriages, and two that recently died. And I think that maternal health is going to be hugely important. I also have seen a recent study that there are less med students going into OBGYN and less matching into residencies of states with abortion restrictions. And I think as we silo states, red and blue states with different laws, we will see less young physicians going to those places to train and to work. We will see more rural areas without access to OBGYNs, to general surgeons, to specialty care in general. We're going to see bigger disparities in this country. And so I think, it all ties into multiple aspects of policy, not expanding Medicaid, not having access to primary care physicians because we don't reimburse adequately with Medicaid or Medicare. All of these policies lead to, especially our rural populations, and then now it's going to be our red states that are going to see disparities in care and lack of physicians. But that's 7 problems in one.
Yeah, there's so many to choose from.
I know. I mean, my goal with policy advocacy is to expand care, expand coverage of health insurance, reduce disparities throughout the US, but primarily in our rural populations that I think get talked about less. We talk a lot about racial disparities and other things, but we do not talk about access in rural communities. We see this a lot because we have so many rural communities where we're the closest major city, all the way up into Oregon, all the way over into Nevada, down the Central Valley, all come to us. And some of my patients travel 6 hours to get care from a specialist. That's a lot to ask of a family. 6 hours each way? That's a whole weekend, whole 3-day travel to ask elderly people to come to get their cancer care. Like, that's ridiculous. But it's because we don't have specialists that they can reach. We don't reimburse or pay those specialists enough. And then we live in this state where we have the most expanded Medicaid and the most expanded coverage. I can't imagine states that don't have those coverage options. So
Yeah.
we'll see. It's going to change a lot, I think, in the next 10 years.
Yeah, there's many people trying to work on this,
Yeah.
including you.
Yeah.
So lastly, what does the future of medicine look like to you?
I think the future of medicine looks more diverse, at least from where I'm sitting in a supported by a medical school. That diversity is very important to them. But even just with recent studies showing that female physicians and female surgeons have better outcomes, I think this caregiving role, that really is what a physician is going to become closer at least to a 50-50 gender ratio, if not more female. And I think the racial diversity is going to change and improve. I think that people are becoming more aware of some of these disparities. So I think the future of medicine, in my perfect world, is leading toward more coverage, more primary care focus, less problem solving in an emergency room focus, and more problem prevention. There's a lot of genetics and immunotherapies and tailoring of medicine to be precise. So precision medicine is huge. And I don't think we will have this, everybody takes the same pill for the same problem. It will be really tailored, which is interesting. I don't know how that'll affect surgery, but we know with bariatric surgery, some patients respond better than others. And I think figuring out that precision of who responds to what procedure and how much is gonna hopefully make all of our treatments, surgical and medical, more effective, more beneficial, less wasteful. But that's probably years and years down the road.
Yeah, I think the personalization of healthcare will be definitely very interesting to see.
Yeah.
Yeah.
It'll be weird to see how it affects surgery. And we probably will be toward the end of the adoption. The medical people, oncologists are the early adopters, and then medicine in general will adopt that, and then surgeons. We're always kind of last, right? We're still behind in gender disparities and racial equity in surgery, much behind our medicine colleagues, and we will lag behind in all the other things, I'm sure.
Well, thank you for this conversation, Dr. Johns. At Oceanside Perspective, we believe in having intergenerational conversations in order to learn from each other's unique experiences. As someone who has yet to find her place in the world, I feel very privileged to speak with someone who has found their passion and is willing to share their experiences with me. It's been a pleasure speaking with you today, and I wish you all the best in completing residency and your upcoming fellowship.
Thanks.
You can do it.
Okay. It's so funny, I can operate, but I can't sit in front of an iPhone.